issue during a midterm exam week. Before we get to that though, I just want to offer the suspects who are involved in this an opportunity to come forward and cooperate with me. If we can have your cooperation, then we don't have to have an investigation. Those individuals can avoid some consequences of such an investigation. And what we can do is make this reissued exam optional to take. So some people did well on the first exam, they want to take it over. Some people did actually poorly on the first exam. They'd be willing to take another shot at it. We would have this option if those individuals cooperate. If they don't cooperate, everybody's got to take the exam. And there's this pending investigation. The evidence that we have is quite convincing. So just think about it. If those individuals do want to cooperate, please get in contact with me before tomorrow. Or you can get in contact with me by 8 a.m. tomorrow. After that, I do have some related meetings. I'd like to get that cleared up to know what we see. Okay? So, any questions on that? Okay.
Is it going to be digital midterm or take it?
That's a really good question. I'm reevaluating a lot of things. There's going to be some procedural changes. I know people like to use scrap paper. I can no longer allow that. Cell phones, you can't even keep that on your person. Yes.
I just don't understand why scrap paper is a problem if you come and look at it and then we give it to you at the end.
Unfortunately, what has happened is that a person can write down something about the questions, switch scrap paper, turn in something to me that did not contain that information, it's a blank piece. That's always been a risk. I've always realized that. However, I know how much people want to use scrap paper. They want to keep track of certain questions, their thoughts, and I think that's a reasonable request from people, but unfortunately, we can't do that.
Oh, this might sound stupid, but what about like a dry erase? Like if you had sheets of paper that were kind of laminated and you gave them out before the exams, and we could get a dry erase marker. That way we will be able to use that only and only that, and all of our materials will be in the front. And that way for people that need that, you know, it would be able to.
I have thought of different ways to provide scrap paper. If one of the options was to pass out a specific piece of scrap paper that each and every individual would get one of, and they would be responsible for turning that particular embossed scrap paper back in. But again, there are just other ways that you can work the system, and unfortunately, as long as that happens, there's going to be some degree of unfairness.
So Dr. Manny, do you have a clear idea of who did this based off your little analysis? Because I just feel like it's kind of effed up for people who worked hard and did decent to have to take a whole new exam, which is probably going to be harder, and then that score, if it's worse, has to replace the score you did well on. So I think it's kind of effed up, if you ask me. But
I wouldn't put it quite in those terms, but I agree with you.
Yeah. But it's just annoying because I was up early, up late to study for your exam for weeks. And I got my score because I worked hard versus other people who cheated, who probably ain't gonna confess, you know. And that's kind of, you know, I think that's messed up. So if you have an idea of who these people are, bring them into your office and talk to them, and with Dr. Lyon, whoever. You know, because I don't understand why you have an analysis and you're not using it to get those people, but you're targeting everybody.
Well, again, that's sometimes people jump to that conclusion and assume that these individuals are not going to be prosecuted. I have to emphasize they're suspects right now.
Suspects.
And you want to make sure we're using that word suspect.
Suspects, gotcha.
If I can establish that the exam has been compromised, that's very easy for me to do. I have a very low threshold to cancel an exam when that occurs.
Mm-hmm.
Actually accusing an individual of cheating is a different level of proof. It requires a lot more investigating, there have to be third parties involved in this. It is not something that one single person should have the power to do. It's to protect the students, it's to protect everybody. It doesn't mean that they're not going to be prosecuted. I have a history of prosecuting students who have done this. This is not the first time this has happened. It's happened in the past. Two individuals who apparently purchased my exam on the black market. The last time.
Wait, hold on. How famous are you? Because
Well, this is
You-
I learned.
I haven't heard it all.
My cardiovascular exam went for over $1,000.
stop lying. I mean, granted, I have lost a lot of stress. Like, I think it's like years of life. Probably 10 of your classes into it. So maybe like all of it.
Well, you can imagine if it's that costly, usually one student can't afford that. So they're gonna go in as a group. And that makes it easier to identify.
Wow.
So the evidence I have right now is very convincing. It varies between individuals. I think it's very easy, at least for one person, I think it's very easy to get a conviction.
Interesting.
So don't, I know that a lot of people are upset about this, they're right to be upset about it, but don't think for a minute that these individuals aren't gonna pay the price. They're already invested, and they've lost. Yes.
So, if we have to take the exam during midterms, what's the scoring gonna be like? Like, how's it gonna be different with the short answers versus what we took, which was all multiple choice?
I still have to work that out. I'm still working out how I'm going to alter everything. And this is gonna be just kind of prototypical, it's gonna be a prototype. So I haven't worked out all that. I do wanna meet with, we have a full-time statistician on staff. And she's gonna be instrumental in this whole service.
Thank you.
Is it gonna be all the information that we learned in class till now? Like, just a new exam entirely? Or is it gonna be the same as, okay.
Just cardiovascular.
Not dermatopathology
It's
also?
dermatopathology if you're on it.
Okay, just making sure it's gonna be the same.
Just the first exam material, yeah.
So just looking at a schedule timepiece, if we have to retake this cardiovascular exam, that leaves us with 8 weeks to do 3 other exams. Are you gonna drop an exam, and we're only gonna do them a total of 3 for the semester, or we're still gonna try to 4?
Oh, this is gonna be given through a midterm exam. We weren't gonna originally use that time slot.
Yeah. No, I understand that, but then we still have 3 other exams to take according to the syllabus, correct?
Right.
So is there
And
still
we'll
enough
be,
time to do that?
when the time comes to take the pulmonary, we'll be ready. We generally have a buffer at the end of the semester. Sometimes we get to CNS, sometimes we don't get to CNS, it's the last topic. Last semester, we didn't get to CNS. I covered the material anyway, but I promised I would not put it on the exam. It was the very last week before finals. And I thought it would be just cruel and unusual to keep jamming material at the end. So we made adjustmts for it.
Okay.
Hypothetically, if someone did come clean and we got to decide if we retake it and you do worse than you originally did, do we get to keep our first score, or is it like a bet? Like,
That's
I
always,
think I'll do better?
that's always a question I get, and honestly, I would prefer that people go in with full focus on that, that you don't have that safety net, so you take it seriously. And when I kind of implement the arrangement that you're alluding to, they don't take it very seriously. So at least some of them.
But like, could you make it, well, I didn't take it, but I'm just saying for the individual who did do poorly, take it again, but what if they fail or something like that, right? Because now everything changes, it's not really their fault. Could you just make it that they would get a pass type of thing? Where it's like pass, fail for those individuals? Because I really think that's kind of unfair. that the whole entire class as a whole is just being punished?
I can't do anything else. The exam's been compromised. I can't do anything else but reissue the exam. That's gonna have to stay. Again, the only variable here is if these individuals cooperate. That's the only variable. Otherwise, it is that exam that you took is just practice. There's nothing I can do. Yes.
We're really only gonna need practice, like to just see what kind of questions we might be looking at for this, the exam type, or like any practice questions, any practice like sessions with you, like before the exam.
Practice, we have, we went through the practice questions.
I think like
I
the
know,
short
but,
answer.
like short answers, we're gonna have short answers on this exam, so I don't know, none of us are gonna be used for that.
Okay.
So we don't know what to expect.
That much I can. Yeah.
I have a similar question. I did relatively well on the exam. I'm feeling comfortable with the material, but I'm fearing that for the makeup exam, you will not be focusing on the main big topics, but make it harder, go more into the smaller details. Is that something I should account for?
I'm gonna be trying to reword a lot of the
Okay,
materials.
same
Again, I haven't offered it yet, so I'm, some of the questions you're asking me are good, but I don't have an answer for you right now, because I haven't gotten to that point where I'm trying to think through everything.
Yep.
And I hate being in this situation as much as you do. I have to write a whole new exam. It takes hours to write an exam. So. Yeah, I'll give them until 8 a.m. tomorrow.
And then we'll know.
I'm sure, I hope the individuals that may have been involved in this are listening very carefully, and they have some scrap of pieces and listen to their colleagues, listen to their classmates, and get them out of this situation. Needless to say, I'm very disappointed in those individuals. Okay, anything else?
Like, when do you feel like the exam for pulmonary is gonna happen in any case? Because I was gonna use the time to kind of like go over some of these things too. Like, now I feel like I have to kind of go back over what we already kind of covered. So there's not really enough time to like cement this information in. So when do you like potentially think that this one's gonna be? So that I can prioritize.
We have to get through the material, then we have to do the practice questions. It's gonna be possibly maybe a couple of weeks after.
Okay, so then I'll have enough time. It's just, I just wanna make sure that wasn't gonna be like the week after we come back and then like now we're gonna have a whole nother exam. That's in a lot of information that I don't have cemented. Okay.
We have just this week left. We've already lost a Monday, so, and we're losing a lot of time here.
Yes. Let's see.
And we got only 2 hours left. All right. That's it? All right, let's take a look at some more of these obstructive and restrictive diseases. Again, we subclassified these major pulmonary diseases based on the spirometric findings. We said obstructive diseases was characterized by a reduction in the FEV1. That's the principal change that occurs in spirometry. There's an obstruction to airflow. Okay, and the restrictive lung diseases are characterized by a reduction in the forced vital capacity. That is simply because the lungs are incapable of expanding fully, and naturally we have a reduction in the forced vital capacity. Okay, so we want to continue looking at some of these things. We were examining some of the chronic restrictive lung diseases, and we said that there's a common feature to all these chronic restrictive lung diseases, and what is that feature?
Exhalation, has trouble on exhalation for restrictive? I'm sorry,
For
did you
a
say?
restrictive lung disease, what's a common histologic finding? Chronic restrictive.
Not the pink frog.
And not expand.
Fibro.
So this is the most common finding that results in an inability of the lung to expand.
Oh, the alveolar dystrophy, yeah.
I can't, if you're saying I can't.
Is it destruction of the alveoli?
The change in the cells, the
That
type 2
is
pneumocytes.
not the basis of a chronic restrictive lung disease. So, we like these generalities because it allows you to make some very good judgments on these exams. The general feature that you find in chronic restrictive lung disease would be scarring of the interstitium. Scarring of the interstitium. So it makes it very difficult to expand these, the lungs if there is a lot of scar tissue. Okay, let's have a look at some of these other diseases that result in chronic restrictive lung disease. Next, we're going to take a look at the sarcoidosis. Now, sarcoidosis is not exclusively a pulmonary disease. It's actually a multi-system disease. It is a disease characterized by non-necrotizing granulomatous inflammation. It's not clear what the etiology of this disease is. Some people think it's an infectious disease. Some people think it's an autoimmune disease. Some people think it's an autoimmune disease triggered by an infection. Whatever be the case, multiple systems are affected by this non-necrotizing granulomatous inflammation, including the lungs. The lungs are involved approximately 33% of the time when someone develops a case of sarcoidosis. Okay? Very often, sarcoidosis will manifest with some relatively subclinical findings, meaning the person really doesn't feel that bad. They don't necessarily know they have it. Sometimes this disease is discovered incidentally on various radiographic tests. Okay? One of the typical findings of someone with sarcoidosis is bilateral hyalolymphadenopathy. Look at the lungs. The lymph nodes in the hilar regions are infiltrated with this non-necrotizing granulomatous inflammation, and they become very large. And so, when you look at it on a radiograph, the finding is bilateral hyalolymphadenopathy. Sometimes that is an incidental finding that leads someone to believe a person has sarcoidosis. Now, once those hilar lymph nodes are involved, it doesn't take much for the rest of the lung parenchyma to be involved. The lung parenchyma starts developing this chronic granulomatous inflammation. That inflammation results in damage, and that damage results in scarring of the lungs. And so gradually what happens is that more scar tissue develops in the lungs. And as that scar tissue accumulates over a long period of time, the compliance of the lung drops. That's what results in chronic restrictive lung disease. Let's take a look at this. Here are two radiographs of the chest. One is within normal limits, the other is of sarcoidosis. And so we see, here's a radiograph within normal limits. You can see, again, the lung field is nice and clear. Cardiac silhouette looks normal. You can see the hemidiaphragms are good. We take a look at the hilar regions. You can see these irregular radiodensities, and again, that's all normal. That's because they've got blood vessels, we've got arteries, large veins, and we got lymph nodes here that are all within normal size. And so naturally that casts some radiodense shadow on the film. Over here we got someone with sarcoidosis. This is a radiograph that is remarkable for bilateral hilar enlargement. You can see the radiodensities of the hilar region are quite enlarged. That's because the lymph nodes in there are enlarged. The architecture of those lymph nodes are effaced with this granulomatous inflammation. Okay? Let's take a look at that. Let's take a look at the architecture of the lymph nodes. And this is the architecture of a normal lymph node. And you can see the section through the lymph node. There's a very diverse population of white blood cells in that lymph node. You have, of course, lymphocytes. We've got macrophages. We've got some blood vessels here. Okay, everything looks good. That's a normal architecture. When someone develops sarcoidosis, these lymph nodes are effaced by this granulomatous inflammation. The entire architecture is destroyed. And this is what you see. Nothing but granulomatous inflammation. And you'll notice we've got, in distribution of white blood cells consistent with chronic granulomatous inflammation. You see a cluster of macrophages, some of which have fused to form multinucleated giant cells, and those in turn are surrounded by lymphocytes. That's granulomatous inflammation. You recognize the distribution. However, you'll notice there's no central area of necrosis. That's why this is called non-necrotizing chronic granulomatous inflammation. This is what characterizes sarcoidosis. It's this odd non-granulomatous, non-necrotizing granulomatous inflammation. All right, now there are other manifestations of sarcoid. Sarcoid involves the lungs again about 33% of the time. There are other systems that are involved. This is a multi-system disease. This is not exclusively a pulmonary disease. 25% of the time, the skin is involved. In fact, it's the skin involvement and the presentation of the skin that earns sarcoid its name. Sarcoid means flesh sheet. And when the skin's involved with sarcoidosis, i.e. when someone develops cutaneous sarcoidosis, they present with very fleshy lesions on the skin, particularly on the face and around the nose. Here's an example of some of these manifestations of cutaneous sarcoidosis. You can see, again, around the nose, we got this kind of fleshy looking lesion. That's where the disease name comes from. Sarcoid means fleshy. There are other manifestations. On the anterior lower extremities, there are these red nodules that are usually very painful. That's called erythema nodosa. These nodules are nodules of granulomatous inflammation. They're very painful. Okay? Another manifestation of sarcoid, cutaneous sarcoid. Now, there are other organ systems that can also be involved in sarcoidosis. Sometimes the eyes are involved. People can go blind as a result of some of the effects of the ocular sarcoidosis. Now, most of the time, sarcoid will respond to steroids. If you suppress inflammation, usually this will go into remission. Some, unfortunately, don't respond to the effects of steroid. You can't get it under control, and the disease will continue to progress. Those that respond to this immunosuppressive therapy, the steroids, a lot of them will just go into remission. Yes?
So sarcoidosis is a chronic restrictive lung disease, but it can cause all these other issues.
It is not classified as a pulmonary disease. Sarcoid is classified as a systemic disease,
Okay.
multi-system disease.
Okay.
It just so happens it involves the lungs.
Got it,
Okay? Now again, the etiology of sarcoidosis not really been established. There's a great deal of debate about that. However, there is something very clear in people who have sarcoid. They have immunologic derangements. They have something called cutaneous anergy. Cutaneous anergy literally means skin without energy. You remember that we talked about the PPD test for TB? Everybody remember that? That's based on a type 4 hypersensitivity reaction. People with sarcoidosis do not mount a type 4 hypersensitivity reaction. We can test this with antigens that each and every one of us should mount a type 4 hypersensitivity reaction to. We use the antigens of Candida albicans. That's a ubiquitous fungus. We all have been exposed to it. We all have antibodies to it. We all have resistance to it. If you take the antigens of Candida albicans and inject that under the skin of any individual here, all of you should mount a type 4 hypersensitivity reaction test. All of you should have a positive test. In fact, that is often used as a positive control in the PPD test. You're dealing with someone with HIV, you don't know if they have an intact immune system, you're actually going to inject them with the Candida albicans antigens. All of them should respond to those antigens. Okay? These people with sarcoidosis don't. They are unresponsive, they lack the energy of a response, That's called cutaneous anergy. Okay, a few other things we need to know. Sarcoid, there is a racial predisposition. Your typical patient, a classic patient with sarcoid, will be a young, otherwise healthy woman of color. It can affect anybody, but it's 10 times, that is your epidemiologic correlate, that's 10 times more likely than any other profile you'll have. Okay, any other questions? All right, a few other things. Now, we mentioned the underlying finding, the histologic finding of all these different chronic restrictive lung diseases. Interstitial scarring. Sarcoid will present with interstitial scarring. It's a disease difficult to manage, and so, as a result, sarcoidosis is generally considered to be a disease of exclusion. It's a diagnosis of exclusion. There are other things that can cause interstitial scarring of the lung. Pneumoconiosis, asbestosis, co-workers pneumoconiosis, borreliosis. You have to rule all those other things out before you can make a diagnosis of pulmonary sarcoidosis. Obviously, if there are other manifestations that allow you to make the diagnosis of sarcoid, these manifestations make it easier. But if you're strictly dealing with lung disease, which again occurs about 1/3 of cases, you have to rule out everything else before you make this diagnosis of pulmonary sarcoid. Basically, you're saying if someone has pulmonary sarcoid, you're just going to have to treat it with this immunosuppressive therapy. It could be that interstitial scarring is caused by something else, an exposure to something that you need to know about. And to stop the progression, you need to stop the exposure. So you have to rule out all those other things before you give a diagnosis of pulmonary sarcoidosis.
That's just for the pulmonary part, but for the other, like the skin stuff, you don't have to rule other things out?
Well, skin stuff, skin manifestations, eye manifestations, other system manifestations, you will be able to, you'll be able to correlate with findings that are not necessarily as critical to rule out other causes. Okay, the sarcoid will be on your differential. It does not necessarily a diagnosis exclusion in those other cases. But imagine you have someone who is presenting to you with a chronic restrictive lung disease. And you've got sarcoidosis is in your differential. And then you discover that they're working in some job that exposes them to asbestos. You definitely want to know that they're exposed to asbestos. You want to stop the exposure. Rather than give it, because if you give a diagnosis of sarcoid, then we're not stopping the exposure here. And so that's something preventable. That would be an unfortunate mistake we made. Yes.
What are the symptoms of this? Like, for sarcoidosis, like, are there any symptoms that are like unique to it because of that person already like having this going on? Because like you're saying that it can be confused with other diseases, but what else could you see clinically that may say that it's this rather than other things?
Well, if you have these other manifestations, plus, again, there's the epidemiologic correlates. There might be a negative history. You're going to be formulating a differential. There'll be certain diseases that you're going to prioritize.
Like, is this accompanied with malaise or fever or anything else that?
Yeah, there are constitutional signs and symptoms of this. So they'll present with fever. You can't bet on it because you don't know the levels of inflammation that are involved. There might be a low-level inflammation. They might present with a very slight fever, or they might present with a substantial fever that you have. Yes.
What did you say the presentation was in the eyes of these patients?
The presentation would be some sort of progressive blindness, Anything else? Yes.
What was the phrase that you used when, if I couldn't find the notes, they don't have a type 4 hypersensitivity reaction?
Cutaneous energy.
Energy. How do you spell energy? Just because I'm not sure about it. Is it A-N?
And energy.
But I don't understand because that kind of looks like a reaction, an allergic reaction. So is it that they have
It's not
antigens
the
against
type-
it?
We're specifically referring to the type 4 hypersensitivity.
Right, but I'm saying you're saying that their skin is lacking of energy in general. So I'm saying, but that looks like it's doing something there. Or is that necrosis that's presenting there? And that's just a death.
This is just a proliferation of fibrous tissue, spindle shaped cells. You think that's an inflammatory response? This isn't that. It is just granulomatous inflammation. But that is not specifically responding to anything. That's just part of the manifestation. Anything else? All right. Let's take a look. All right, so are there any questions about restrictive or obstructive lung diseases? Okay, that completes that section. So we got these major divisions of pulmonary diseases, obstructive, restrictive. You should probably make sure you understand which diseases are under each head. So, typical thing I'll ask you on an exam, I'll present you with a patient with some history. I'll also give you things like forced vital capacity, FEV1. You'll immediately be able to subclassify it as obstructive or restrictive. Then I'll give you some timing, and you'll be able to subclassify it as chronic or acute. And then if you know the different diseases, you'll be able to isolate the diagnosis. All right. If there are no other questions about obstructive, restrictive, let's just first start discussing pulmonary vascular disease. And we're going to start by talking about pulmonary hypertension. So we discuss hypertension a lot, but again, if we mention hypertension, usually what we're referring to is systemic hypertension. That's high blood pressure on the left side of the circulatory system. And of course, we've got definitions for this, classifications for this. But sometimes hypertension also develops on the right side, and that's called pulmonary hypertension. There are many causes for pulmonary hypertension. Sometimes there is some sort of left to right shunt, meaning that blood is being shunted from the left side to the right side. And now the right side is overwhelmed with blood. That's going to increase pressure on the right side. Sometimes there is some sort of vascular disease in the pulmonary system that's causing increase in resistance to blood flow. That's going to increase pressure on the right side. Whatever be the case, pulmonary hypertension causes progressive disease. And once this pulmonary hypertension starts, it's very difficult to treat, it's very difficult to reverse. Okay. Other things that can cause pulmonary hypertension include increase in vascular resistance. Blood flow has more difficult time flowing from the right side to the left side. One cause for this could be an imbalance in the vasodilators and vasoconstrictors in operation in the pulmonary parenchyma. This is thought to be the cause of a type of pulmonary hypertension called idiopathic pulmonary hypertension. Idiopathic pulmonary hypertension by name, well, we don't really know what causes it. However, it's thought to be some sort of imbalance between vasoconstrictors and vasodilators. Your typical patient will be a young, otherwise healthy woman. Certainly, other other categories of a patient can develop this, but the typical patient's gonna be a young, otherwise healthy woman. Let's take a look at some of the possible causes. We'll skip all of this, we covered this already in other classes. Okay, here's one possible causes of pulmonary hypertension. You section through a blood vessel, again, there's the lumen, there in the endothelial cells. Remember, the endothelial cells are supposed to constantly produce nitric oxide. Nitric oxide is a powerful vasodilator. It has a short half-life, it only is locally active. These endothelial cells are supposed to produce nitric oxide, they go back here and back diffuse into the wall to relax the smooth muscle. That keeps the blood vessels widely patent. It's easy for blood to flow through there. One possible cause of idiopathic pulmonary hypertension is a failure to properly produce this nitric oxide in the pulmonary system. Other things can happen. Maybe not enough vasodilator is being produced. Maybe cells are not responsive enough to vasodilators. Maybe too much vasoconstrictor is being produced. Maybe cells are overly sensitive to vasoconstrictors. There are many different causes, but this is certainly one of the causes that seems to be linked to idiopathic pulmonary hypertension is a failure to produce this nitric oxide to keep the blood vessels widely patent. Now, there are some very serious complications for pulmonary hypertension. The right ventricle isn't that powerful. It with response to the hypertension will naturally hypertrophy. You probably will develop isolated right ventricular hypertrophy. Nonetheless, it's going to be difficult for the right side of the heart to pump blood through some of these very constricted blood vessels. And people are going to develop manifestations of a reduction in cardiac output. So they're going to become possibly cyanotic because they can't oxygenate. They're going to become easily fatigued. They'll have exercise intolerance because cardiac output is significantly reduced. While all this is going on, the high blood pressure actually causes some structural changes to the blood vessel wall. Let's take a look at this. Here's a typical blood vessel you might find in the pulmonary system. It's an arterial. Again, you got these certain proportions. There's the lumen, there's the blood vessel wall. That's a normal looking blood vessel. This blood vessel were to constrict, we could probably treat it with some sort of vasodilator. Unfortunately, in pulmonary hypertension, the constant high pressure causes structural changes in that blood vessel wall. And the lumen starts to become stenotic. If this is what a normal blood vessel looks like, this is what a blood vessel would look like in the pulmonary system after people develop pulmonary hypertension. There's the lumen, there's the wall. You can see how thick the wall is. These seem to be reactive changes that go on in the pulmonary system. And the longer this hypertension goes on, the more of these changes occur. Now, as a result of the structural changes, it's very difficult to treat pulmonary hypertension. Systemic hypertension, it usually responds to vasodilators. And you get blood vessels that are constricting to dilate, that's great. How do you get a blood vessel like this to dilate enough to restore proper blood flow? Once you get these structural changes, there's no vasodilator more that's going to dilate that blood vessel. And as a result of structural changes, make it very difficult to treat pulmonary hypertension. Pulmonary hypertension doesn't respond well to antihypertensives because of those structural changes. Then when you get to a point so bad, the only way to treat pulmonary hypertension might be with a lung transplant. You have to actually remove the lungs, the vasculature along with it. Sometimes the pulmonary vessels almost completely occlude with structural changes. There's a section through the lung, and there's the alveolar part of the lung. You can see that. There's one of the blood vessels. You can see the circumference of the blood vessel there. You'll notice that the lumen of the blood vessel is almost completely blocked with a lot of cellular proliferation. Completely obstructing, almost completely obstructing the lumen. How do you treat that with an antihypertensive? You can't. So pulmonary hypertension doesn't respond well to antihypertensives. Now the body tries to make an effort to open this blood vessel up. You can see there's some little cannulae, but that's not going to help very much. Okay. Someone has pulmonary hypertension. In addition to all the reductions in cardiac output and some of the manifestations resulting from the reductions in cardiac output, the cyanosis, the exercise intolerance, there are actually some findings that one can identify at an autopsy that are nearly pathognomonic for pulmonary hypertension. On the left side of the circulatory system, atherosclerosis is pretty common. That's because atherosclerosis, the high pressure on the left side of the circulatory system promotes a lot of that atherosclerosis. You very rarely see atherosclerosis on the right side because the blood pressure on the right side is very low. And that low blood pressure does not promote the formation of atherosclerosis. However, when you have someone with pulmonary hypertension, the atherosclerotic plaques develop on the right side just as easily as they develop on the left side. And so when you see atherosclerotic disease on the right side, that's nearly pathognomonic for pulmonary hypertension. Something you would find at autopsy. Here's a cut into the lung. You can see a blood vessel here. Some normal lumen here. Look at this. There's an atherosclerotic plaque right there. You never find that in a person who does not have pulmonary hypertension. It's just very, very uncommon to see. So when you do see it there, your first thought is, oh my God, this person probably had pulmonary hypertension. Okay, any questions on carotid? All righty.